This is Courtney Peden. My student number is 11397914. Okay, so Sarah's come in. She's been pushing for an hour and 20 minutes already with not much descent of the head. The head's just been born and it looks like it's pressed really hard against the perineum. So what I would do is I'd get her to, I'd wait for the next contraction, get her to push again like normal, just see if that anterior shoulder will come. If not, I'll immediately call for help. As a junior midwife, haven't got the experience behind me to deal with situations like this, so I would give a quick handover to the ONG team, preferably the consultant, and get him to take over care, but for the purposes of this VIVA, I will explain the manoeuvres like I'm the one doing them. Okay, so like I said, I'd call for help straight away. I get the NICU team called and the ONG team to have them there. I'd give them all jobs to do. I get one person to document, one person to take the end off the bed for easier access, and things like that. I'd then consider if she needs an episiotomy. There may not be enough room to do one, and it may only help if we get to the internal manoeuvres. So I would quickly lay her flat on her back and get her to assume the McRoberts position with her thighs right up to her chest, holding them down. If that doesn't work, I'd get her in that position for 30 seconds. And then if that didn't work, I would apply cerebropubic pressure, so just above her symphysis pubis for about 30 seconds. And if that's still unsuccessful, I'd try for an additional 30 seconds in a rocking motion, trying to free that anterior shoulder. For the next manoeuvres, I'd encourage her not to push because this will only further obstruct the anterior shoulder. So next I'll do the Rubens 2 manoeuvre, which is leaving the woman in the McRoberts position, slip my hand in posterior into the vaginal wall, work my hand around to the anterior shoulder and then put pressure on the anterior shoulder, trying to decrease the diameter of the baby's shoulders. If that's still unsuccessful, I'd maintain my hand in the on the anterior shoulder, but put my hand on the posterior shoulder and try and rotate the baby's shoulders clockwise for about 30 seconds again. If this doesn't work, I would try and rotate the baby in the opposite direction, which is the wood screw manoeuvre. If this is still unsuccessful, I would find the baby's posterior shoulder and splint the arm across the baby's shoulder and then stretch it out across the baby's face, which will lead to it being born, which again decreases the diameter of the shoulders, which are in the pelvis. If this still isn't successful and the baby's not born, I'd roll onto all fours, which will try and increase the pelvic diameter. If not, then I'd prep her for theatres to do an emergency lower segment caesarean section. So with shoulder dystocia, I'd be expecting this baby to come out with low apgars. So the NICU team would be there, so I'd immediately clamp and cut the cord, put the baby straight on the resus trolley for ped review. I'd also want to take cord blood, as the mum's O positive, to rule out hemolytic disease, and the mum's also hepatitis C positive, so I'd want to do blood tests on the baby to ensure that the baby has not picked up this. I'd also want cord blood gases taken, which will help determine the extent of fetal distress that the baby suffered, especially if it's been a long dystocia towards the final manoeuvres. So after birth, I'd want to consider Sarah's well-being. She had a really low HB in pregnancy, and with a prolonged second stage of labour, there's a very, very high risk of postpartum hemorrhage. So I'd put that 40 units of syntocinon up in 1 litre of Hartmann's, and may have ergometrium ready to go if that's not working. I also have ONG in the room still, so they can deal with her care and their plan of action for her as well with that. And make sure her fundus was firm and central and well contracted. and would do regular postnatal checks to ensure that this stays the case. I'd want to debrief with Sarah because of an obstetric emergency. There's not really that much time to explain to the woman what has to happen. Ideally I'll have a midwife there who can help explain to the family what's going on, what's happening and why it's happening, but also give a chance for Sarah to understand what has happened to her and the reasons that we've intervened the way we have. Just a chance for her to say how she's feeling and everything like that. Make sure she's doing okay emotionally. And yeah, so that's it. So hopefully we'll have a happy baby, happy mum. Thank you.